Hey guys, Mrs. Hall here. We are continuing with Nursing Series 3101L. Today we'll be dealing with solution types, preparing the IV fluids, drip sets, calculating flow rates, Intracaths, IV starts, creating an anchor, removing an IV, ampules and vials, and reconstituting IV fluids. It's a little bit longer than my typical video, but I believe you will enjoy it. I have here some swabs in a container, a pad to put under the patient's limb, a tourniquet, options for Intracath sizes because I will evaluate which I can use when the process is started. In this case, 500 ml of fluids will be hung and the tubing that's needed for the connection. My trash and sharps container are located just within reach so that I can readily dispose of the sharps and keep both myself and the patient safe. On the side, I have some tongue depressors, which are commonly used as splints for pediatric patients to prevent them from displacing the IV in movable joints. The last item on the list may not be readily visible since the tape has been pre-torn for efficiency. When considering solutions, the physician must be aware of how the body works with those solutions, and so must the nurse in order to safely administer them. The first step in understanding is to grasp the process of osmosis, which is how molecules pass through a semi-permeable membrane. Cells are selectively permeable. Each cell in our body works at keeping things perfect, but cells are picky. They're not happy if it's too hot, if it's too cold, if it's too watery, if it's too acidic, or if it's too salty. The effects of IV solution fall under the categories of being too salty or too watery, so we'll stick with that. The process of diffusion causes concentrations of fluids to shift in an attempt to fix imbalances. In the cells, the only thing that diffuses is water, but the water molecules are very attracted to salt molecules. So the water in the cells that is not attached to any salt molecules are more likely to relocate to create what the body feels is balance. In caring for patients, we administer 3 types of fluids: hypertonic, hypotonic, and isotonic. The suffix tonic means concentration of a solution. So each of these solution types has a different concentration. Isotonic fluids are the body's favorites because, as the prefix iso indicates, that the concentrations are the same. There are no changes that the cell need to make in order to make them happy. These fluids are used in cases of blood loss, dehydration, or surgery. Examples of these are solutions like the normal saline, the lactated ringers, or the dextrose 5. Now, there's something important to know about the dextrose 5. When administered, the body quickly metabolizes the dextrose and the fluid then becomes hypotonic. You will notice that at times, the solution is used as an isotonic solution or a hypotonic solution. Now, hypotonic solutions have the prefix hypo, which means less or under. This has a smaller concentration than the cell content. The cell works to become the same as the environment by absorbing the water from outside the cell. This causes the cell to grow because of taking in water to create balance. It can lead to rupture of the cell, called cell lysis. Hypotonic solutions also cause decreased circulatory system fluid and hypovolemia because the water from the blood goes into the cells. It's like the body dehydrating itself by drawing fluids from the circulatory system. This can be useful though in cases when a diagnosis includes cell dehydration, diabetic ketoacidosis, or hyperglycemia. Examples of these fluids are low concentration salines like the 0.45 or the 0.22 or the 0.33, and the D5. Remember, we spoke about D5 being used as a hypotonic solution. Finally, hypertonic solutions. The prefix hyper means too much, and that is exactly what the concentration in the environment is. too much. So the cell feels the need to create balance by releasing water. The water rushes out the cell and the cell contracts or shrinks. This is called plasmolysis. Hypertonic fluids includes high concentration salines and dextrose, like the 3% or the 5% saline or the 10% dextrose. It also includes the saline and dextrose or the saline and lactated ringers. These are administered in cases like hyponatremia or cerebral edema because they help these cases because the body can create a balance for those conditions by decreasing fluid retention. There is a caveat though. These would most likely be administered by central line because they are very caustic. They can cause phlebitis. The fluids must be closely administered as they can quickly cause overload. In summary, note that hydration is a drug and should not be taken lightly. Let's prepare the IV fluids for administration. The package for the IV fluids must be inspected that it is intact and within the expiry date. There is a pre-torn slit on the bag that aids in opening the package. You would have checked that the fluids you are preparing is what is ordered for the client and the volume of the bag is suitable. There are 2 ports on the IV bag. One for the administration of medication or withdrawal of fluids, and the next is the port where you would spike the bag. The little blue tip is twisted off for access. Before you open your drip set, you need to observe the package for the drop factor. Macro droppers have a drop factor of 10 to 20 per ml, and micro droppers have a drop factor of 60 drops per ml. We open that package in a similar manner because it also has a pre-torn slit. A little about drip sets. Here we can see 3 common options: the blood set, the macro dropper, and the micro dropper. The blood set has a blood filter and a drip chamber, unlike the other sets that only have a drip chamber. Blood components must be filtered during transfusion to remove clots and small clumps of platelets and white blood cells that form during collection and storage. The patient end of the blood set has a cannula connector. The microdrip and macrodrip refers to the diameter of the needle where the drop enters the drip chamber. In the microdropper, you can see an actual needle protruding in the drip chamber. The macrodropper has a larger needle that enters the drip chamber. Drip sets also carry a vent. This is used to regulate the flow rate along with the roller pump. Here, you can see a roller clamp and a Y connector. The roller clamp, or flow control, has 2 parts, the roller and the slide shaft. Sliding it downward closes off the fluid and upward opens it more. The Y connector or injection port allows for access to give medication or boluses without interrupting the flow of IV fluids. The end of the macro or micro dropper have a lure lock collar which can screw onto needles, heparin locks, or other devices. After screwing off the protector for the infusion port, you spike the bag with the dropper spike. When it is well secured, the roller clamp is closed off to prevent the flow of fluids in the drip chamber. The drip chamber is squeezed to allow a fill of 1/3 to 1/2 of the chamber with fluids to prevent air from moving down the tubing. This must be done well to avoid introduction of air and foreign matter to the closed system. Hang the solution container on a pole. Adjust the pole so that the container is suspended about 3 feet above the client's head. This is needed to enable gravity to overcome venous pressure and facilitate the flow of solutions into the vein. The roller clamp can then be opened after hanging the fluids on the drip stand to prime the tubing. The term prime means to make ready, but in common use, it refers to the flushing of the tubing to remove air. Air bubbles smaller than 0.5 ml usually don't cause problems in peripheral lines. For caps with air vents, don't remove the cap when priming the tubing. The flow of solution through the tubing will cease when the cap is moist with 1 drop of solution. When infusing IV fluids, the nurse must know how to calculate the IV drip rates. IV fluids can be administered using a gravity feeder, which is a roller clamp on the tubing, or by way of infusion pump. The drop factor is the number of drops in 1 milliliter of solution. For this session, we'll focus on micro and macro droppers. The macro dropper flows at 10 to 20 drops per ml, which is most often used to infuse large volumes of fluid quickly. The micro dropper flows at 60 drops per ml. This is used for more precise infusion of fluids, like when you're caring for a neonate. Your drop factor can be found on the packaging of the IV tubing. The first thing you need to find is the number of milliliters that is needed per hour. That's basically found right within your orders. 500 mLs over 6 hours. The total volume over the total time in hours. That will give you your mLs per hour. With that information, we can find that the rate that the IV will flow. Your total fluid is on the IV fluid container, and the time needs to be converted to hours if it's not given in hours. Now, when calculating your flow rate, that's done in drops per minute. This might be one of the most difficult parts to wrap your head around. Your orders are received in milliliters per hour, and you want to find drops per minute. In this case, the time needs to be converted to minutes since we are looking for drops per minute. If we were using a macro dropper with a drop factor of 20 drops per ml and administering 500 mLs over an 8-hour period, you would use this formula to get your drops per minute. Volume in ml over time in minutes, multiplied by the drop factor, which is in drops per ml. Try to do the same thing, thinking as if you have a micro dropper with a drop factor of 60 mLs. Your volume in mLs over time in minutes multiplied by your drop factor to get drops per ml. It is important to note that intracaths or cannulas not only come in different gauges but also in different lengths. In general, the smaller the bore, the shorter the cannula, to suit the needs of pediatric patients and the like. The gauge is the size of the cannula. Cannulas run from 24 gauge at the smallest to 14 gauge at the largest. The gauge refers to the inner measurement or opening of the needle. The larger the gauge or number, the smaller the bore of the needle. You will note on this chart that the drop factor will also be influenced by the size of the intracath. As an example, if you have a patient that requires fluids at 20 drops per minute, you will not be able to achieve that with a 24 gauge intracath because of its capacity for only 13 ml per minute. These are a few examples of the types of intracaths you may come in contact with. Most equipment come in packages with easy open tabs so that they can be thrown onto a sterile field or simply taken out of the package if it's a clean procedure like starting an IV. This is an example of an intracath. While inserting the intracath, you can touch the lower lock fitting, but not the cannula itself, because that goes into the skin and remains there. Touching it can introduce bacteria to the patient. This intracath is encased in a hard plastic shell with paper seal indicating sterility. If the paper seal is broken or damaged, you should not use it. Twist the case by holding the top and bottom pieces firmly. Here we have a catheter that comes with a 1.2 ml syringe. This can be very useful when you need a small amount of blood for tube samples. This one is a little different because it has a spring-loaded button that retracts the sharp end of the intracath. This is aimed at preventing needle sticks. When using this type of intracath, you need to release the tip seal by holding the colored hub or lower lock device to rotate the safety barrel. This helps to orient the bevel and ensures that the button is facing upward. Not doing this can affect your ability to advance the catheter and retract the needle. Perform hand hygiene and observe other appropriate infection control measures. Prior to performing the procedure, introduce yourself and verify the client's identity using whatever kind of protocols that exist for your institution. Explain to the client what you are going to do, why it's necessary, and how he or she can participate. Make sure that the client's clothing or gown can be removed over the IV apparatus if necessary. Select a venipuncture site using the non-dominant arm if possible. The tourniquet must be tight enough to obstruct venous flow, but not so tight that it occludes arterial flow. Obstructing arterial flow inhibits venous filling. When dilating the vein, gravity slows the venous return and distends the vein. Distending the vein makes it easier to insert the needle properly. Apply a tourniquet about 6 to 8 inches above the venipuncture site. If the vein is not sufficiently dilated, you can massage or stroke the vein in the direction of venous flow, or you can encourage the patient to clench and unclench the fist, which causes the contracting muscles to force blood along the veins, distending them. Or you can lightly tap on the vein with your fingers to distend the veins. Avoid vigorously rubbing the vein or spanking the patient, since this causes hemolysis, which can alter labs slightly or significantly, especially in values like potassium showing a false increase. At this point, you can make an assessment of the right size cannula for your patient. Be aware of the needs for that site and choose accordingly. Patients receiving blood and blood products need to have a larger bore intracath than those receiving fluids and medication only. Clean a site using aseptic techniques from clean to dirty using a circular motion or single strokes before the puncture occurs. Ensure that the fluid is dry before you puncture. Make sure that your intracath is bevel up. You want to hold the bevel up to allow the sharp tip to pierce the skin first, paving the way for the rest of the needle. Entering the vein beveled down causes a painful tear to the skin. Hold your catheter in a manner that allows you to see the flash or flashback in the catheter chamber, and later the needle flash. The flash is when the blood is returned as a result of hitting the vein. Hold the catheter at a 15 to 30 degree angle and insert the catheter through the skin and into the vein. When the flash is achieved, the cannula is advanced while holding the needle in place, preventing further damage to skin tissues, which could lead to a rupture in the vein as the needle cuts through the vein further. After the entire cannula is in the skin and the male end of the lower lock is all that can be seen, the introducer needle is completely withdrawn. In order to minimize the occurrence of overflow of blood, pinch a location at the cannula would end to block off the blood flow while you release the tourniquet and continue to collect your samples or connect your IV or heparin lock. Clean up the site of any spilled blood to ensure that moisture does not affect the adhesive on the tape. Be sure to always keep a keen eye on maintaining your intracath in place until you have secured it. To secure the intracath, you will need 3 main pieces of tape. A thin one to anchor, and then a wider one, which is usually the other half that the thin strip was cut from, that secures the anchor. Both of these should not obstruct the function of the lower lock. The final piece is meant to secure the IV tubings, so that if there is any tension that occurs, the anchor bears the brunt of the force and the IV is not displaced. To remove the IV, it's important that you keep in mind that the patient discomfort may arise from the adhesive on the tape. You carefully lift the ends of the tape and apply a cotton swab and pull on the intracath. Apply firm but light pressure onto the site for a short while to stop the bleeding, and then apply a band-aid. As a review, please remember the 5 rights of medication administration to reduce medical errors: the right patient, right drug, right dose, right route, and right time. Ampules have a top, a neck, and a bottom. Ampules are made of glass and should always be cleaned before breaking to avoid contamination of the content. You will have to remove all the liquid from the top before cracking it by gently flicking the ampule with your finger. In some settings, you may have a ClickSmart device that you can put over the top of the ampule to create an easy break at the neck without injuring your fingers. In most cases, though, you will not have this and need to be aware of how to crack the neck. The ampule can have a combination of painted lines along with cutting lines or microscore, which is a line around the neck, or a score point, which is a single dot to indicate the weakest area on the neck. The vial may also just be plain with a score point or a microscore. If your ampule has a score point, always crack the ampule away from the colored dot. To pull up the medication, you gently insert the needle into the ampule and aspirate the required content. Be sure to change your needle before administering medications to avoid discomfort from damage to the needle as the medication was withdrawn from the ampule. Vials have a bottle and a self-sealing rubber top. There are many different sizes of vials depending on the needs of the provider. You can see here vials with 2 ml to 100 ml of fluids. The top of the vial is also important to note, as there are several types, some that require a cap to be popped off, or those with a metal top that needs to be removed. It is often done with a syringe to avoid damage to the skin and nails while working in a healthcare setting. To pull up the medication, clean the rubber stopper of the vial with an alcohol swab. Pull back on the plunger of your syringe to the line of your dosage and fill it with air. Filling the syringe with air prevents a vacuum from forming inside the vial. This could lead to contamination of medication with subsequent use, which is significant for future use. Inject the air into the vial as you tilt the vial to avoid air aspiration to the syringe, and you will notice that the fluid automatically starts to fill the syringe. When you have required dose, hold the syringe up and tap it to remove any excess air and ensure that the fluid is the correct amount. Be sure to change your needle since slicing through the rubber stopper compromises the quality of the needle and can cause increased discomfort when administering medication directly to the skin. Some drugs must be stored in powdered form because they rapidly lose their power once they are mixed into a solution. These drugs will have to be reconstituted or mixed in a liquid. That liquid is called a diluent. Most often, sterile water is used as a diluent, but you will also find saline or lactated ringers used, but try to stick with sterile water to be sure. Never use D5 as it causes crystallization with many drugs. Typically, we add the diluent and calculate the dosage of the drug based on the amount instilled. However, it is of note that you need to pay attention to the label of the vial to see if the diluent and reconstituted amount are dictated by the manufacturer. In this example, we can find that the solution can be diluted in 3 ml for IM use and 10 ml for IV use. The label further states that when that specified amount of diluent is used, the available volume becomes 10.6 ml if it is a 1 gram vial and 11.2 ml if it is a 2 gram vial. This accounts for the powder that then becomes a part of your diluent. You will not commonly see this in your practice, but it is important to note in case you come across it. Since we lack this information in many drugs labels, we calculate based on the volume of diluent used. To calculate your dose, if you have a drug that is in a 1 gram vial and you use 5 ml of diluent, the patient dose is needed. If the patient is to receive 250 milligrams, then you would use the formula as follows. The patient dose multiplied by the volume divided by the total dosage in the solution, using the same measurement as the patient dose. I will send a few practice questions for you to process this information thoroughly. When reconstituting your drug, it works similar to the use of a vial. You clean your vial and then you have your diluent. You insert the diluent into the vial, mix it thoroughly, And after you finish that, you withdraw the required amount of fluid. Be sure to tap out any air that may be in there to get the correct dosage.